Prenular 5, you went over that. Did Dr. Olgan talk to you about what the function is, or mostly about like attachments from the brain stem? Final destination function, fibers, motor fibers, sensory fibers, so
Oh,
V3,
wow. Okay.
choose,
You guys didn't have a childhood.
sort of, possibly. It'll all come together, I know, yeah. So today, what we'll do is consider the GI tract, the tubular GI is the title here. So we'll start a little bit with the esophagus, and then mostly the intestines, stomach and intestines. Next week we'll do, it's called GI glandular, so we'll take up mostly like liver, pancreas, salivary glands, which we kind of mentioned yesterday, but not in any detail. We'll come back to those. So I think the way this will go today, I have the lecture, and then I have some lab material, some atlas images for the lab, and then also some PhD images that we'll go through and we'll try to interpret those. I think what I'll do is I'll just take my time with the lecture and maybe use a little bit of the lab time to complete that. And then we'll have our lab, hopefully get some interaction there. I kind of like it when you become lively and ask questions, and I really do appreciate that. It lets me know where you are and whether I'm connecting with you or whether you're just wondering, what is he talking about? Okay, so let's begin then with the GI tract, and just in the way of where is it? So the GI tract is mostly going to be contained in this cavity that we call the abdominopelvic cavity. And it's shown here in the diagram from your textbook. It's in yellow and green. So the abdominal part is shown in yellow. The green part is the pelvic part. And the boundary between those is the division between the greater pelvis and the lesser pelvis, the arcuate line. That's a familiar term to you? Yeah. So it's where you spill down into the lesser pelvis or true pelvis. So that's what's shown in green here. And so here is a diagram or a painting of the GI tract, the tubular GI. So that's what we want to maybe literally straighten out today, or figure out what's what. It looks like it's kind of a tangled mess, if this is really the first time you've kind of dealt with all the parts. It's really pretty nicely organized, and it's very orderly, even though it looks like just piled up and coils and everything else. So what we're going to deal with, as I mentioned, was the esophagus, which we know that begins at the distal end of the laryngeal pharynx. The esophagus is just a muscular tube that descends down through the thorax, and we'll look at that during the lab portion. I'm not going to have much to say about it right now. It's going to pierce the diaphragm and then join with the stomach, which we can see here. That's this kind of J-shaped sac right here. This is where food ends up when it leaves the esophagus. Of course, it's going to be stored there. That's where digestion is really going to begin. And then as we go over here towards the right side, or the distal end of the stomach, there's a connection between the stomach and the small intestine. The small intestine is going to have three named parts, the duodenum, the jejunum, and the ileum. And the ileum, the distal end of the ileum, then down here in the lower right region of the abdomen, is going to join with the large intestine. And the large intestine then has this ascending part, a transverse part, which does show up nicely here. Then it disappears, but it continues as a descending part, and is going to run then, the descending part is going to run down here on the left side and join with something called the sigmoid colon, which becomes continuous with the rectum, which is down in the pelvic portion of the abdominal pelvic cavity. And then the rectum is going to join with the anus. And then the anal canal is like the outlet. So here's another way that we organize these regions. We talk about a foregut, a midgut, and a hindgut. That becomes very important, especially when we talk about the arterial supply, but these terms are derived from the embryological development of the GI tract. And you haven't studied development yet, embryology. I think you're gonna do that so we'll talk about foregut, midgut, and hindgut, but understanding that you haven't studied the embryology yet, so we won't, we'll just try to appreciate that. So here are the derivatives of the foregut, and then on this slide, which again is a diagram from the textbook, I've just added these red lines which indicate the divisions between, in this case, between the foregut, which is here. It includes part of the esophagus, the stomach, and this is the duodenum right here that extends way over to here. It's this U-shaped structure. Part of the duodenum is derived from the foregut, and part of it, the distal part of it, is derived from the midgut. And then the midgut also includes the remainder of the small intestine, so the distal end of the duodenum, all of the jejunum, all of the ileum. And here we see the ileum joining the large intestine. So that's a very distinctive juncture. There's no question about what's small intestine, what's large intestine here. The same is not true for the transition from jejunum to ileum. To really understand that transition, you have to look at the histology of the GI tract, and I know you're not doing that yet either, so that's going to come in the spring, I think, so you'll hear about that. And it's not, again, not a real dramatic transition, even histologically, but so this more proximal region is going to be jejunum for sure, and this more distal region down here would be ileum. And then we have the transition to the large intestine, and the large intestine here is, I mentioned that has the ascending colon right here, but it actually begins with a structure called the cecum. The cecum is just like this blind ending pouch right here, so it's this portion of the large intestine right here that's inferior to what we call the ileocecal junction. And then we have, again, the ascending colon, and then we have this very sharp flexure, which we'll talk about. I don't have the name here, so I'll just wait till we get to another slide. This is called the transverse colon, this horizontal, more or less horizontal section. Then we have another very sharp flexure, and we have the descending colon. Now this line right here is the junction between the midgut derivatives and the hindgut derivatives. So we're going to include the proximal 2/3 of the transverse colon is going to be midgut. The distal 1/3 of the transverse colon will be hindgut, and then the remainder of this large intestine will be hindgut derivatives. So one of the reasons we're interested in organizing the GI tract this way, foregut, midgut, hindgut, is because even embryologically, that's the way the blood supply is organized also. So if we look at the next slide, we have these same parts of the tubular GI system, but we see the arterial supply added to the diagram. So what we're looking at here is the dorsal aorta, the abdominal portion of the aorta. There are lots of branches coming off here, but what is shown in the diagram are 3 large visceral branches. These are unpaired, and each one comes off the anterior surface of the aorta, and I'm sure from yesterday's session, you already know the names of these arteries, right? So the most superior one here, the celiac trunk, not surprisingly, that's going to go to all the derivatives of the foregut. So distal end of the esophagus, stomach, proximal portion of the duodenum. The arterial supply will come from the celiac trunk. Immediately inferior to the celiac trunk is superior mesenteric artery, goes to the midgut derivatives, so distal end of the duodenum, jejunum, ileum, cecum, ascending colon, and the proximal 2/3 of the transverse colon. And then finally, inferior mesenteric artery. No surprise there, that's going to be hindgut derivatives, so distal third of the transverse colon all the way to the rectum. So there are many named branches that come off of these vessels. We'll touch on a few of those. We won't go into, when I say pancreatico-duodenal artery, is that familiar? Is that word familiar to you? No. I would say good. I couldn't remember. I think it was last year I mentioned that. They already knew what it was, and that was, so that's kind of getting beyond the detail that we're doing. So that makes quite a bit of sense, right? That's a pretty good overview of what we're going to be dealing with. So in the next slide then, we're looking at the GI tract now, and so we have some idea of how it's organized in there. It's kind of packaged very tightly. We might not recognize all of that, but we now recognize the stomach. We can't see the duodenum over here, and we're going to learn as we go on that the duodenum is actually located in a way we refer to as retroperitoneal, so it's up against the posterior abdominal wall. So that's why we can't see it. A large amount of the small intestine is actually covering it, but the duodenum is going to make this U-shaped turn like this, and then it's going to join the jejunum over in this region. So these red lines I put on here indicate 4 quadrants of the abdomen. And when a healthcare worker, a physician, will be palpating the abdomen, they might be feeling, say, for hardness or lumps or something like that, but they know what's in their mind, they know what is contained within each of those quadrants, right? So, and that's kind of the purpose of the lines here. So in the upper left quadrant, you're going to have a portion of the stomach. A lot of the stomach is contained underneath the rib cage, but some of it protrudes away from there. You have parts of the large intestine and parts, especially of the jejunum up here in the upper left quadrant. In the upper right quadrant, you're going to have some large intestine, but also parts of the jejunum also, and maybe some of the ileum. In the lower left, you're going to have lots of ileum. Well, actually, in both the right and left lower quadrants, you're going to have lots of ileum. And famously, the lower right quadrant is going to have the appendix. So that's, lots of times people will arrive at a clinic with, they'll often describe they started off with pain that just kind of emanated throughout their abdomen, and then it localized down in the lower right quadrant, and that often means appendicitis. I'll just go back a couple slides here. I didn't mention this when we were talking about the general organization, but here's the origin of the large intestine. I refer to that as the cecum. And attached to the blind end of that pouch is this structure here, the appendix. So you can see how that would be pain that is generated from that could localize to the lower right quadrant. And then this, a lot of times, I just put this in here kind of for your own information. I won't be asking questions about this, but a lot of times physicians will refer to not just the quadrants, but the 4 quadrants of the abdomen, but they'll talk about the 9 regions. So they just add rather than having a median vertical line and a horizontal line that goes through the umbilicus, they'll have I guess, a mid clavicular line on the right and left, and then a subcostal line and an iliac, a line between the tubercles on the ilium. And you get these nine regions there. So just so you're aware of that. So let's look at these various parts then of the GI tract. We'll start with the stomach. Say a little bit about the esophagus. You can see it attaching to the stomach here. So we'll look at it as it comes through the thorax in the lab slides. But it's going to, as I said, it's going to pierce the diaphragm and then join with the stomach. And as you can see, this is occurring over here in the upper left quadrant. And then there's, so the stomach itself is basically this, usually referred to as a J-shaped bag, pretty large. And it has several defined regions. I'll show you some of the details of that in the next slide. But the main portion here is the body. But you can see these two curvatures that characterize the stomach. One here is called the greater curvature. This is more inferiorly located. And then this more superiorly, this narrower fold is called the lesser curvature. And then over here at the distal end, towards the right upper quadrant, the stomach narrows down and there's a valve here. This is the pyloric end of the stomach, and there's a pyloric valve here that keeps the contents of a meal in the stomach long enough to turn it into a chyme that is ready to go into the small intestine, where digestion will continue, but absorption of the nutrients will also take place. So and in the anatomy lab, it's always interesting because you can take this region of the bag and palpate that. It's just like this flaccid, big, thin-walled bag. But then as you move down to this region right here, where it's labeled pyloric canal, and there is of course, a canal, a tube that goes through there, but the wall thickens and the smooth muscle creates a sphincter, a pyloric sphincter. And it almost feels like there's a golf ball of this stuck in there. It becomes very hard, and then, of course, that's going to that can relax then and allow the peristaltic waves that form in the wall of the stomach, which is largely made up of smooth muscle. That's something you'll deal with in histology, though. The peristaltic waves then will push the food through that pyloric canal into the duodenum, which begins right here. So the other things that we're going to talk about this a little bit later too, but you see these sheets, these membranous sheets. There's one right here, and then there's this big thing right here. This is actually kind of like an apron. It looks like fat. There is a lot of adipose tissue in there. It's referred to as the greater omentum. This is called the lesser omentum. This is part of the mesenteries that hold the GI tract in place. It allows it to be mobile, but it also kind of holds it in place. So later in the lecture, we're going to talk about all of the mesenteries together and how they attach the GI tract mostly to the posterior abdominal wall. But since these mesenteries are so evident here in this slide, we'll just point those out. Say we'll come back to them. So lesser omentum and greater omentum. Okay, so here are some of the details of the stomach itself. I mentioned, of course, the greater curvature, the lesser curvature, and the joining of the esophagus. This area in here is the body of the stomach. The region around where the esophagus joins is referred to as the cardia. And then this blind ending pouch up here, the portion above the juncture of the esophagus and the stomach is referred to as the fundus. And fundus is a term, just a general term that doesn't specifically apply to the stomach. It's just like the end, like the blind end of a tubular organ. So The bladder, urinary bladder had a fundus. The gallbladder, we haven't talked about yet, it'll have a fundus. And then the stomach too is just, so this, like opposite the outlet is the area of the fundus here. There's lesser curvature, greater curvature, and then this antrum. Antrum is like a term for hallway or entryway. So it's like the entryway into the pyloric canal here. So that's the pyloric antrum. And then this is the region where you have that pyloric sphincter. So this is where when food arrives in the stomach, this sphincter is going to be closed down. And as the stomach churns and mixes the food with acid and other enzymes, it just, the valve prevents that food from moving directly into the intestine until neurological, physiological signals then indicate that the valve should relax, the pyloric canal opens, and the peristaltic ways will begin to allow the food or push the food into the duodenum. Okay, so then the duodenum. Now I mentioned that when we looked at that initial diagram, we could see the large intestine, the small intestine, but we couldn't really see the duodenum because it was posterior. So here they've arranged the drawing so that you can see it, but really you have to move they just kind of lowered the GI tract, the large intestine and small intestine, but this portion, you can see that the duodenum is U-shaped, and except for this superior part right here, which is suspended by mesenteries and actually visible at the distal end of the stomach, the rest of the duodenum here is actually attached directly to the posterior abdominal wall, so very deep in the abdominal pelvic cavity. So you can see it forms this U-shaped region. And the duodenum is generally spoken of as having 4 parts. I don't have them listed here. We'll go through them. You can write these down. So there's this superior region, the first part, and you can say superior or first part. Those people would know what you're talking about. So here's the first part. It's horizontal here. And then it turns sharply and descends. This is the descending portion or second part of the duodenum. And you can see there are going to be some connections here between the liver and the pancreas and the duodenum, but we're going to talk about those connections next week. The third part of the duodenum then turns sharply and goes over towards the left. This is referred to as the third part or horizontal part. And then what's not really indicated in this diagram, right here, the horizontal part will ascend, and so that we have a fourth part or an ascending part of the duodenum. And then you have the connection with the jejunum that you see right here. So the U-shaped duodenum is going to join the jejunum, and then that fourth part comes off of the posterior abdominal wall and is more visible in the anterior region of the abdominal pelvic cavity. We're going to learn later what retroperitoneal means and intraperitoneal, and we'll relate that back to the duodenum also. Okay, so then we're going to go on with the jejunum and ileum, and here's a diagram that's just showing the jejunum in blue and the ileum in orange. And it's also superimposing those quadrant lines that divide the abdominal wall into upper right and left and lower right and left. And you can see the general arrangement of the jejunum and the ileum. So you can also see, here's the duodenum right here, the U-shaped duodenum. You can see is once food leaves the stomach and goes through the duodenum, it's going to enter the jejunum here in the upper left quadrant, and then in general that food is going to move towards the lower right quadrant, so kind of down this direction, even though it takes a lot of zigzagging to get there. And here's where the ileum then is going to join the large intestine. So here is a medical image then of what the small intestine actually looks like, and when a physician does anatomy on it. So what they've done here is had a patient swallow a contrast agent, usually barium, which they can actually just swallow. Give it time to go through the GI tract and then take x-rays, and you get an image that looks like this. This can be pretty confusing, but if you look up here, of course, we have the stomach, and over here on the, this would be the upper left quadrant, and we can see the region probably around the cardia and the fundus. Here's the body of the stomach, and then look right here. In this region, see how it narrows down? That's the pyloric canal. That's where the pyloric sphincter is that would, in this case, keep some of the barium contained in the stomach, but just open up periodically to let some of it through. Here's the duodenum. So we can see this descending portion, and the portion, and then it becomes horizontal and moves over towards the left. And then it's just like chaos breaks out. We can't really, it looks like maybe it goes around like here, but goes back up. I don't know, it's going all over the place. But down in here is where, it looks like maybe right here, it's going to join with the large intestine, which is going to go up through here. But I'm estimating now, I'm not sure. But at least you can see the stomach, the sphincter, some of the duodenum, parts of the small intestine now, so that makes a little bit of sense. I just on here, I say estimate the location of the jejunum and ileum, so in the upper left here, I would think this is largely jejunum, right here, and then down in this region would be ileum. So then here is the ileum now. We're looking at this region, in this bigger picture, we're looking at the region in the red square right here. So here's the cecum, the distal end of the ileum, and the cecum has the appendix there. Here goes the large intestine, the ascending portion of the large intestine. So the ileum is going to penetrate the wall of the ascending colon, and if you take that anterior portion of this large intestine away, you see these two little lips in there. That's an ileocecal valve. So when the large intestine has peristaltic waves that begin to move the food superiorly up towards the transverse colon, the pressure waves actually cause those lips to push together, so that you don't get retrograde flow of the food product back into the ileum. So that does a little bit of guarding there. The other thing you see at the inferior end of the cecum right here is another opening, which indicates the attachment of the appendix. The appendix is surprisingly variable. I know a lot of students will be surprised. Sometimes it's, almost a foot long, and sometimes it's, it's skinnier than a pencil like this, and maybe only 4 or 5 centimeters in length. And of course, often when students are dissecting, they look for an appendix and they don't find it because it's been removed. This is very common surgical procedure where the appendix becomes inflamed just because like fecal lifts, like hardened pieces of feces, sometimes will get trapped at the opening just inside the appendix. Like the intestine is a hollow tubular organ, and if the lumen gets clogged up, then you can get distal to that, the blockage. Like down in this region, it will become inflamed and be very painful and need to be taken away. Okay, so let's look now at some of the characteristics of the large intestine. It looks very different than what we were looking at for the small intestine. The small intestine had, of course, a smaller diameter. We call it small intestine because of that. It's way longer than the large intestine. But it didn't really have any defining characteristics on the outside surface. It was pretty just smooth tube. But the large intestine is characterized by these structures that I mentioned here. Haustra, which are these little like saccules. And there are something else called omental appendices, or they're also called epiploic appendices. So these two terms, omentum and epiploic, are synonyms. I think one is Latin and one is Greek or something like that. I tried to figure this out one time. I looked up omental, what was the origin of that term, and it said epiploic. That wasn't very helpful. So, but they're either term. But if a physician prefers one to the other, they'll just use that one, and they may remember the other one or not. But either one of those is fine. And what are they, though? They are just little bundles or packages of adipose tissue that are attached to the large intestine, and you can see them all along here, these little fat appendages. Epiploic appendices. So they're present even in lean people. They're not indicative of being overweight or obese or anything like that. They're just characteristic of the large intestine. The other thing that you see here, actually you kind of see it better in the diagram over here. You see that stripe across there? That is like a ribbon of smooth muscle. There are 3 of them. They're called Taenia coli. So when you study histology, you'll learn that the entire GI tract has a muscular layer that consists of 2 distinctive layers. The innermost layer includes a circular arrangement of smooth muscle cell, and then just outside of that, there's smooth muscle that it's arranged in longitudinal fashion. So you have an inner circular and an outer longitudinal layer. And the outer longitudinal layer in the small intestine is just very uniform, forms just a uniform layer of smooth muscle. But in the large intestine, you have the longitudinal muscles, but in 3 different places they're thickened to form these ribbons, which we refer to as the Taenia coli. And these Taenia coli, I think, also explain the haustra, those little saccules. It's almost like you think of the Taenia coli, you have these ribbons that aren't quite as long as the large intestine itself. So the Taenia coli almost act like elastic bands that cause the cause the large intestine to kind of fold up or shorten by forming these little haustras. Does that make any sense? So the Taenia coli are shorter than the intestine, and in order to just cover the entire length of the intestine, it just gets packaged, or just gets kind of almost like an accordion. So, yes.
Is there
Any omental appendage, is there any role, any function of those fat appendages? So I don't know of it. I know medically they can sometimes become ischemic and painful. That's rare, but I know of a case where that recently happened. But it would be an energy reserve, but there's no real known function. Kind of odd, but they're very characteristic. The other thing about the Taenia coli, not the omental appendages, but the Taenia coli, the 3 of them, they have the same origin, site of origin, which is at the blind end of the cecum, which is also exactly where the appendix is attached. So in the old days, when appendices were moved in by an open procedure, an open surgical procedure, a surgeon would open up the abdominal wall and just reach in and grab the cecum, which is quite mobile, Some of the ascending colon is not so mobile. We'll talk about that, the reason for that a little later. But they would just grab the cecum, pull it out, kind of place it on the abdominal wall. And then if they needed to, if the appendix wasn't obvious, they could just trace one of the Taenia coli down this way onto the cecum, and that would lead directly to where the appendix should be attached. Take it off. So taking the appendix out basically means identifying the appendicular artery, supplying it, ligating that, and then cutting off the appendix and putting it back. Well, so, okay, so, and then, all right, so then we have the large intestine. It looks the same all around, all of us. This is where the large intestine begins to fall over the pelvic brim, go down into the lesser pelvis, and this region is called the sigmoid colon. And it's also characterized by the mesentery that is attached to it. Again, we're gonna talk about that in a little bit, but you can see this bit of mesentery here, whereas there is none associated with the descending colon. So I will say that both the ascending colon and the descending colon are like the duodenum in that they are attached to the posterior abdominal wall. And again, when we talk about the mesenteries, that will make sense. But then, like the jejunum or ileum, this portion of the large intestine, the sigmoid colon actually does have mesentery attached to it, so it's not attached directly to the posterior abdominal wall, but it's more anterior and more mobile. And then all of a sudden you see the epiploic appendages disappear. There are no haustra here, no Taenia coli. This is the rectum, and this would be down in the pelvic cavity now. The true pelvis. And then the rectum, and this is a site, so by the time the food that's been digested in the stomach and passed along from the stomach gets into the large intestine, mostly what's going on here, Dr. Olden will talk more about this, but the nutrient absorption has taken place, and now mostly what you're doing is taking water or conserving water from the feces. It gets a little more solid, and then it can be stored in this more distal region, but also in the rectum. The rectum is really just a site for storage, and then during bowel movement, there's going to be a relaxation of sphincters down around in the wall of the anus, and I think I mentioned the pelvic diaphragm when I talked about the abdominal pelvic cavity. It extends from the diaphragm that you talked about when you were talking about respiratory systems, right? So you have the diaphragm up here, but there's also a diaphragm inferiorly, a pelvic diaphragm. And that is what is indicated right here, this little like fold around the rectum there. So the rectum is going to pass through an opening in the pelvic diaphragm and lead into the anal canal, and muscles in the diaphragm and also in the wall of the anus will relax to allow the movement of feces to the exterior. Okay, so now here is how a physician might be looking at the large intestine. This is again a case where a patient has swallowed barium. Some time has passed. They allow it to be moved on. I'm not exactly sure how this is done. I don't know if it was just time that allowed that material to move out of the small intestine, but the small intestine is not indicated here at all. It could also, well, I don't know how that, but anyway, this has a lot of labels on it, but I think you'll be able to figure out what's what. So here, we're looking at the lower right quadrant now. The C is indicating the cecum. This is also, the appendix would be attached here. So this is the origin of the large intestine. Here is the ascending colon, And now something happens right here, it gets it's hard to follow the channel. And I don't think I mentioned these terms, I should. If we look over here in the diagram, the ascending colon turns very sharply, I mentioned that. This is referred to as the right colic flexure, or maybe more commonly, it's referred to as the hepatic flexure, because this is going to be very close to the liver. Hepatic referring to the liver. So the right colic flexure or hepatic flexure would be right here. So the ascending colon is going to rise up, turn very sharply, and I think that's what the H is for here, yeah, the hepatic flexure. And then we have the transverse colon running from right to left, and the U is that's referring to each one of these little saccules, the haustra. They're very clearly there in all regions of the large intestine. They show up very nicely here in the transverse colon. And then as we go over towards the left, you see there's this elevation right here where the S is. That can be variable. And then you have another one of these sharp folds or turns, flexures. This is the left colic flexure, maybe more commonly referred to as the splenic flexure, because the spleen is going to be right over here adjacent to where this turn is taking place. And then from the splenic flexure, you just go down into the descending colon. It's attached to the posterior abdominal wall, but then the sigmoid colon is the next segment, and its location is variable, its length is variable, because again, it's not attached to the posterior abdominal wall, it's attached to a mesentery, it's very mobile. And then that, all of a sudden, the haustra disappear, and if we could see them, the epiploic appendages would disappear, the tinea coli would disappear, and here you have the rectum. And then we're not seeing the anal canal, the anus right there. It doesn't have barium in it. Yeah, question?
What are the purpose of the flexures?
The purpose of the flexures? So it's really just to accommodate the packing of the large intestine. There's no specific function. It's just so the small intestine is, I think there's a number on your slide that says 6 to 7 meters. So 18 or 20 feet long. The large intestine isn't nearly that long, but it's still like maybe 4 or 5 feet long. Just to get it all packaged into the abdominal pelvic cavity requires all these coils and loops, and the flexures are just how, I guess embryologically, how the whole tube comes to be packaged in that region. So it's really just to accommodate this great big long tube into the smaller abdominal pelvic region. There's nothing different like in terms of the function of the intestine that's part of the flexures versus the parts that are ascending or descending. How long are the small intestine? That's what I was saying. I think the number I put on the slide is 6 to 7 meters. Oh my God, it's very long. Yeah, so like 18 to 20 feet long. But you can't just, like if you're looking, if you were in looking at a surgical field where the abdominal wall was open, you couldn't just lift that intestine out. I mean, it's attached, and we're gonna talk about that in a little bit, so. Crazy, yeah. It's pretty nicely organized, though, it's not, yes.
Is that also
Shortens it. Yeah, so the question was, is the purpose of the tinea coli to just basically shorten the large intestine so it fits in the abdominal pelvic cavity? I see your point. They're usually not thought of that way. Again, the haustra don't have any specific purpose either. I mean, the purpose of the large intestine, besides storage and transport of the digested food, is, that's really absorbing water, and Dr. Olken will talk more about this, and forming the feces. There's no great explanation of exactly why you would have these haustra. It's kind of just the way it is. I think you've had Dr. Mahaney, I think, for several lectures over here. He's famous for saying, why are there haustra? That's a God question. I don't, yeah. I like that, because when I don't know the answer, I just refer to Dr. Mahaney and God. So, any other questions? I guess the major point here is just the different elements: stomach, duodenum, jejunum, ileum, large intestine, how they're packaged in there. So the next thing I want to talk about is it relates to how the intestine is, all the GI tract is kind of held in place, because every abdomen you open up, you're going to expect to find the stomach in a certain place, and you almost always do. The organization of the small intestine is going to be very typical. The large intestine is going to be very typical. And that has to do with these structures called mesenteries. And to start talking about the mesenteries for the abdomen and the GI tract, I think it's maybe easiest at this stage to think back to the lungs. And I'm sure Dr. Dunn talked to you about pleural cavities, visceral pleura, yeah, parietal pleura, and the space between those two layers was the pleural cavity. We have the exact same thing in the abdomen, except instead of saying pleura, we say peritoneum. So we have parietal peritoneum, we have visceral peritoneum, and we have a peritoneal cavity. So now we have, and all of this is in the big space that I referred to initially as the abdominal pelvic cavity. Okay. So this is a picture that Dr. Dunn probably showed you something very similar to this. This is the balloon, blown up balloon with the hand going into it, and she probably told you that hand was the lung. And the portion of the balloon that's touching the lung is called the visceral pleura. And then it turns right here, it comes off the hand. We say it reflects, the visceral pleura reflects off the lung, and that portion then is called parietal pleura. So all this would be parietal pleura, and it would be attached to the thoracic wall. So now all we have to do is kind of mentally change the order of things, and the hand is going to be the GI tract. And the GI tract is going to have visceral pleura, visceral peritoneum, and the visceral peritoneum will surround the organ. It will reflect off and be attached, in most cases, to the posterior abdominal wall, except for some very small elements that are attached to the anterior abdominal wall. Is that clear? Yeah, okay, pretty simple idea. But now if we look at this sagittal section through this specimen here, the pink is the peritoneum. And of course you can see the cut through tubes here. Of course here's the stomach. Here's loops of the small intestine cut at different angles, some longitudinally, some in a circular profile. The pink that is immediately attached to those circles would be visceral peritoneum, okay? So there would be parietal peritoneum attached to the anterior abdominal wall here on the posterior surface, all along right here, it's not that easy to distinguish. Let's go down here, here's the urinary bladder, it's below, or subperitoneal, it's not. Here's the parietal peritoneum going up the posterior abdominal wall now, up, 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 up. But look at right here, see how it turns sharply and begins to go over this structure right here, which we're gonna refer to as a mesentery. And here it goes out and now begins to cover all the entire small intestine and becomes associated also with the large intestine. So you can see this. So in general, we're going to refer to these membranous sheets as mesentery, but there's going to be one structure that's actually referred to as the mesentery proper, which is what's going to be suspending the small intestine. So is that clear, okay, or is that a little bit confusing? Yeah, question. So the omentum is part of the mesentery, so it's not different, it's just a location. So just like the pleura, Dr. Dunn may have mentioned, it's a serosal membrane, so it's just a simple layer of epithelium. It secretes a little bit of slippery fluid so that as the intestine is making peristaltic waves, it's mobile, it doesn't stick to other tissues or other organs that it touches, but it causes a nice smooth surface that can just again be slick and accommodate these motions. I think I just looked at the clock. Let's take a break and then we'll continue on with this.